Good evening, everybody. Thank you for joining us this evening. This is our second program of the COVID Conversations. And tonight we'll be welcoming Dr. Oliver Brooks and Dr. Rob Schechter, who will talk about vaccine prioritization plans, as well as the state's vaccine logistics and administration plans. So basically the who, what, when, where, and how of the COVID-19 vaccines. So first, we have just a few housekeeping slides. Next slide, please. Basically, you are automatically muted for the duration of the talk, the presentation. If you have any questions, please type them into the question answer box on your screen. If there are any technical difficulties, there's a link there, and we will also post that link in the chat box so you know how to contact if there are any issues. For the question answer
in the chat box. Sorry.
Perfect. For any questions and answers, look for the box. I believe it's on your on the panel on the right of your screen that says questions. We received over 200 questions at the time of registration, even before the start of this presentation, but we will try to answer as many as possible. Next slide, please. The California Immunization Coalition is a nonprofit public-private partnership dedicated to achieving and maintaining full immunization protection for all Californians to promote health and prevent serious illness, disability, and death. And the American Academy of Pediatrics California is a partnership of the 4 local California AAP chapters. We are committed to the attainment of optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults living in California. So it's a partnership. We're proud to bring this together. Our future COVID conversations will be Dr. Peter Hotez on Monday, February 8th at noon. He will be talking about COVID vaccine hesitancy and combating misinformation, which will definitely be an important topic as we roll out these vaccines. Next slide, please. The COVID vaccine guiding principles, as you could see there, particularly for California, it will be guided by the following principles. The vaccine meets safety requirements. The vaccine is distributed and administered equitably. People with the highest risk of infection will get the vaccine first. Community stakeholders are brought in from the outset for transparency. Next. And a safe and effective COVID vaccine will be one of the most important tools to end the COVID-19 pandemic. California will be transparent, careful, and above all, equitable in its vaccine distribution. Next. Dr. Eric Ball and I are your moderators today. I am Dr. Pia Pannaraj from Children's Hospital Los Angeles, and Dr. Eric Ball is from Children's Hospital Orange County Primary Care Network. Next slide, please. And Eric will be introducing our first speaker today.
Thanks, Pia. I am pleased to introduce our first speaker today. So this is Dr. Oliver Brooks. Dr. Brooks is the past president board member and the past president of our organization, the California Immunization Coalition. He's also the chairman of the Immunized Los Angeles Families Coalition. He serves as a member of the National Leadership Panel for the Adolescent Immunization Initiative. He also is the immediate past president of the National Medical Association, which represents over 55,000 African-American physicians in the United States. He's the chief medical officer and past chief pediatric and adolescent medicine at Watts Healthcare Organization in Los Angeles, and is medical director for LA Care Health Plan. And he's here today speaking in his role as one of the co-chairs of the drafting guidelines work group through California, working on setting the guidelines for COVID vaccine administration. Please join me in welcoming Dr. Brooks. Thanks for joining us.
All right. Thank you very much, Dr. Ball, and thank you for the participation of the American Academy of Pediatrics that you do represent. So Good evening to everyone. I was asked to present information on the rollout of the COVID-19 vaccine in our state and am happy to do so. Next slide, thank you. No, I have no conflicts as it relates to disclosures. Next. So one of the guiding principles of the vaccine rollout, allocation and rollout, is equity. So as past president of the National Medical Association, the NMA, I just wanted to give a definition of racial equity because I think that sometimes is overlooked in terms of the true definition. So it is the distribution of resources and opportunities is neither determined nor predicted by race, racial bias, or racial ideology. The structures, systems, and practices, cultural narratives in society provide true situational fairness and equal opportunity. And there's a democratic commitment, small d democratic commitment, to dismantle the false narrative of white supremacy and address legal, political, social, cultural, and historical contributions to inequity. So I think that last bullet is important. So not only do we want to have equity, but we want to work against the forces that may have provided inequity. Next slide. So next. So this is just a simple graphic showing the difference between equality, which is giving everybody the same, versus equity, which is making adjustments based on need. And that is a fundamental concept of equity. And that is also what is guiding us as part of our allocation, as I stated, of the vaccine. Next. So we are having disparities in COVID-19 outcomes, hence we have to allocate appropriately. These are three areas, I think. Okay, next. Next. So underlying conditions we all know of. Those that are highlighted was for another talk. Those relate to cardiac disease, which is the #1 killer in this country and among African Americans. And this is CDC data. Next. So why are we having to determine specific allocation? So this is a slide from when I am on the ACIP COVID-19 work group that determined how the ACIP made recommendations to the FDA, and then as it was approved going forward into the MMWR. So in the beginning, there was, as projected, going to be a short period of time when the doses were limited before we could get up to phase 2. If you think of the phases as we described them, this is where they come from. Phase 1, which is where we are right now, phase 2, which is where we hope to be soon, and then phase 3, which is, we hope to be there, let's say by the end of the year or before that. So, and this shows some information, but I think that this slide is probably from about 3 months ago, but this was what guided us. So I think that's very important to just note this, because when we started with this, we now have refined it very much. We see phase 1A and 1B, and then the concepts there, and then phase 2, and then 3. Next slide. So who are the people that we were most concerned about in terms of phase 1? And there are numerous reasons for the determination that these were the groups. So you see healthcare personnel, the smallest number. Next would be the adults 65 and older. And we will talk about that as we move forward. Essential workers, 60, 80, and high-risk medical conditions. So these would be 4 groups of individuals that would either be as high likelihood to get the disease, or if they got the disease, it would have a negative impact on our society. So once we looked at healthcare workers and age, we were looking at industry, or how do you allocate it based on occupation industry. So in California, there are 13 industries, and they're specifically defined, and these are the 13 here. Next. So an industry is different than an occupation. So an industry is defined, occupation is self-reported surveys, It deals with what kind of job it actually is, not what sector is it in. And industry is also called sectors. I should be clear on that. Some of it, the data is based on where an employee lives, not where their office of their company or their industry. And it's based on how they self-identify, as I was stating. So you see, as opposed to an industry, which shows the type of business, administrative data is based on where they work, not where they live, and it's based on official unemployment. We come with that based on official unemployment insurance filings. So that's where we define our sectors or our industries. I think the example at the bottom is good. If a truck driver works for a lumber company, the industry is forestry and logging. The occupation is transportation, so two different ones. And an accountant working for the same lumber company would have an occupation as business and finance. Next slide. All right, so there's a group called the Community Vaccine Advisory Committee, and there was a statement in the beginning about transparency and equity. So that group has 80+ members. That is a broad section of our society here. Covers unions, public health, teachers, healthcare workers, and others that disability, the aged. So they were convened to give us advice and direction. So these were the 4 areas that were found to be the criteria used to allocate vaccine. Societal impact, that's where healthcare workers came. If healthcare workers got sick, they would not be able to take care of you all in a pandemic. Equity, so those are people that theoretically may or may not need the vaccine, but assuming they needed the vaccine, may not be able to get it because they don't have access to health care, they may not have proper transportation, may not be able to get off from work. So equity is a very important factor. Occupational exposure. So obviously, if you're in a lockdown, but those are people that have to work, those people are more likely to get infected. And then the one that we felt was the least important, or excuse me, they felt, the Community Vaccine Advisory Committee, the impact on the economy. So wage and price stability, so that keeps your economy together. Scarcity of workers, maybe only a small number of those workers, but they could affect, if you're a bond trader, California can't sell its bonds, we may be in a financial crisis. And then looking at schools, child care, families. So a teacher needs to teach so children can go to school so people can go to work. Next. So this shows the distribution of the critical infrastructure, which is the, other than healthcare, which were these industries that we were referencing. And you see that the largest number, other than, let's say, other educational services, and then farm and agriculture. So this just helps us when we were working on to see how many people were in a particular sector when we made the allocations determinations. Next. Next. Am I still connected? Hello?
You are, we can hear you.
All right, go back one, please.
Sorry, there's just a slight delay. Thanks.
Oh, okay. So this was what we were now getting to California. This is what we were expecting in phase 1A. We were expecting about 2.5 million doses in December, a cumulative 6.5 in January, 12.5 in February. So there were about 25 million in our phase 1. So we were expecting to have about half, and again, why therefore we had to allocate. We have not gotten this much yet. That we can talk about that. Next slide. So this is just a graphic of how we would roll it out, transitioning from phase 1A to 1B to 1C to 2. So you don't wait for one phase to totally be completed. Next. So the work group considerations, and this was coming, some of this was out of the CDC, ACIP. So prevention of morbidity and mortality versus preservation of social functioning. So again, kind of how do you determine, and these are how they were ranked. So morbidity and mortality, you would look at the aged, those in long-term care facilities, and in terms of social functioning healthcare personnel, and then essential workers, which aligns with what we have determined. Next. So this was what was 1B proposed as of yesterday. It's funny because this is a moving target. So this is a proposal. This I believe Rob can state. I think this was actually released today. It's interesting when you're on these panels of what has been released, what is proposed, what is known, what is still under discussion. So the proposal, okay, if 1A, which is not even here, was healthcare personnel and those in long-term care facilities and adult assisted living facilities. So we're deep into 1A right now. 1B, which is where the discussions are, generally looking at 65 and older, because the federal government Monday made a determination that we should drop it from 75 to 65. And those in those sectors that are at high risk of exposure at work or in a critical function, in other words, societal impact, determination is education, childcare, emergency services, food and agriculture. So childcare goes under education. They're separated here, but there were 3 groups plus the age determination. And then looking at, and that's why I have them crossed out like this. So we had 65 to 74 in 1B, but looking at moving that to tier 2, but looking at moving it to tier 1, and that's why I just lined it out, because that was a change. And then so we went to the next level of those who are in these essential worker category, transportation, logistics, industrial, commercial, residential, sheltering, facilities and services. Go back, please. Back one more, there, right there. And then critical manufacturing, then congregate settings, because you just have risk of outbreak there. Construction workers was felt to be important, and so they are in industrial commercial. So that's the occupation, not the sector or industry. Next. And then looking at 1C, looking at those that are 50 to 64, those that are high risk, and the other industries or sectors that were not previously mentioned in part of the 13. So there are 7 there. Next. So just very briefly, I'm the Chief Medical Officer at Watts. So just in terms of some of the things that Dr. Schechter may speak to, this is what we had to go through. We had to enroll, then we had to receive approval from CDPH, we had to notify the county, we had to enroll in PrepMod, which is how you monitor vaccines. Then we had to get our vaccine, we had to put together a team, we had to prioritize our healthcare workers based on those things that discussed would be, and the prioritization was occupational exposure, age, and then equity. We vaccinate, then we report back to LA County DPH, and then we order more vaccine. Next slide. So just wanted to state briefly that this shows 1, 2, 3, 4, 5, 6 safety monitoring systems. So when we give the vaccine now, post-marketing, which is phase 4, these are existing monitoring systems. Next. More existing. So that was general public. That was, well, stay where you are. So what happened is there was expanded safety monitoring because of this new vaccine, vSafe, which is a mobile app, and then the NHSM, the National Healthcare Safety Network. So these have been rolled out to ensure that there's even deeper or more intense monitoring of the vaccine as it hits the population. Next. So there was concern about people jumping the line. So this was from the Sacramento Bee, governor stated Monday that the state will enforce the order of people receiving vaccinations, issuing a warning to medical providers who may be tempted to cut a friend or relative in line. They just want to make crystal clear, if you skip the line, you'll be sanctioned. And there was not language stating this in the official, as opposed to from Sacramento Bee, in the guidelines that we are following here at Watts Healthcare and in South Los Angeles. Next. So, again, this was the me first, so there was concern regarding that. So next slide, I believe last slide. So I said, yeah, I guess I can go, maybe not first, but early on. So I'm seeing patients on the floor at MLK Hospital. So I'm a healthcare worker exposed. So I was able to get the vaccine, and I recommend it for everyone. So that ends my presentation. Thank you, Dr. Ball, and I am available for any questions.
Thank you so much, Dr. Brooks. Congratulations on getting your vaccination.
Thank you.
So we had a lot of questions roll in before and during the webinar. I have a question about equity. So, you started out talking about how there are certain populations which are disproportionately suffering from COVID-19 morbidity and mortality. Was there any thought to prioritizing groups based on race or ethnicity?
The concern with doing that is it may seem being focused on a lens of race, and so which there may be some legal ramifications. So it was thought about, but the real feeling was that when you look at underlying conditions, if you look at socioeconomic indices, so there's a HPI Healthy Places Index, there's a SVI Social Vulnerability Index. If we utilize tools such as that, that may capture those that just do, because it's a reasonable statement. Racism in and of itself is an independent factor to poorer health outcomes beyond all those other indicators. But we felt that it probably was best to utilize other factors so that there was, for people who weren't caught in that equity, that it was truly equitable beyond race. So in the end, no, we did not use race.
So we have a lot of educators on this call and had a lot of questions about educators. I was happy to see that they are, I guess, next up to go once the healthcare providers are done. Can you talk about the thought process about vaccinating childcare workers, teachers?
Right. Well, again, the basic premise was that the societal impact was heavy. If a teacher has COVID, they can't teach, children can't go to school, people can't go to work. B, if you are teaching in an open environment versus a lockdown environment, you are exposed. So what we did is we, on the drafting guidelines work group, of which I'm co-chair with the next speaker, we looked at all the sectors and we scored them based on those 4 indices: equity, societal impact, exposure, and effect on the economy. And so we did it in I'd say an objective fashion, like a spreadsheet. And education came as one of the top indicators, or one of the top that would be allocated. But I'd say primarily because of what I stated.
So when you look at the people who are going to be vaccinated and the order in which they're going to be prioritized, a lot of them are very clear cut, right? Like, you're over 65 years of age, you're a teacher. We have this nebulous category of people with like pre-medical, with medical conditions, right? I mean, I would imagine that's a huge chunk of the adult population of the United States has obesity or hypertension or what have you. Do you think this is going to be an honor system, or are you going to need to bring your your diabetes medicine with you to the vaccination center? How are we going to figure out who qualifies for those tiers?
For those that are being vaccinated at health systems, they will tell us that they have the data, like Kaiser, Sutter, Dignity. They have that information. But for outside of those health systems, which is likely where most of the vaccine will be, so you make a valid point, it's not really clear. There will be somewhat of an honor system. Yeah. I'm hoping that a lot of them will be captured. What we found is that when you go through these essential worker categories, 68% of Californians get caught or get captured, if you will, and being an essential worker, which I think is an interesting statistics. So even if they have an underlying condition, may be hard to prove, they may get 2/3 of them are going to get vaccinated just because they're an essential worker.
That makes sense. Final question before we turn this over to Dr. Schechter. Thoughts about people who do not have health insurance or undocumented people living in California. How do we capture them? How do we ensure that they get vaccinated as well?
So a good question. So some of those are farm workers, for example, just as an example, especially in California versus, let's say, Delaware, where there are just not that many farm workers, I imagine. So that was one of the driving forces for them being in one tier one. So good question. So that is part of the logistical challenges that we have. So it'll go to a particular county, and that county will be charged with having outreach. So part of the discussion of the Community Vaccine Advisory Committee is to make sure there is outreach. So for example, I'm in an FQHC. I see uninsured individuals. So in LA County or in South Los Angeles, where I'm located, they can come. They don't need to have insurance, and we don't check immigration staff. So, you know, whether they're undocumented, we don't know. We don't care, quite frankly. So the FQHCs and the state has reached out to FQHCs. So I appreciate the fact that that was thought of. So we are to be, we mean FQHCs throughout the state are supposed to be, and will be a vehicle by which these those will be vaccinated.
Excellent. We appreciate all you're doing. You know, as you go through this, we realize what a heavy lift this is and how complex this is. Thanks for everything that you and Dr. Schechter and everyone else is doing to keep our state safe. And with that, I'm going to turn this back over to Dr. Pannaraj, who's going to introduce our next speaker.
Great. Thank you, Dr. Brooks. I have the pleasure of introducing Dr. Schechter this evening. Dr. Rob Schechter is Chief of the Immunization Branch for the California Department of Public Health, and he's been a medical officer there since 2003. His work includes management, program implementation, vaccine safety, post-marketing surveillance, vaccine communication, information health technology, and vaccine research and development. He has also consultative roles for CDPH's immunization programs, including the California Vaccines for Children program, and he's a member of the National Vaccine Advisory Committee, which advises the U.S. Department of Health and Human Services. He also serves on several work groups for the for ACIP, the Advisory Committee on Immunization Practices. So he has quite a lot of experience and is leading the charge here in California. So we are very pleased to have Dr. Schechter lecture for us today.
Thank you for the kind introduction, Dr. Pannaraj, and thanks Dr. Ball and thanks Dr. Brooks. Can you hear me? I apologize for being off video, but I'm hoping that my audio is okay.
Perfect.
Yeah, we can hear you well.
Thank you. So following Dr. Brooks, I just would like to quickly go through some slides. I might skip some in order to free up some additional Q&A time to try and answer as many of your questions as possible. So next, please. Next, please. So these are the two current vaccines in the formulary, the Pfizer-BioNTech and the Moderna vaccines. Unprecedented pace of development, unprecedented regulatory schedule, back-to-back meetings over a long weekend of several review groups at FDA, ACIP, and then a newly convened group of experts from the Western states, including California. Next slide, please. Comparing and contrasting the two vaccines, slightly different minimum ages, a week apart in the minimum intervals, 3 versus 4 weeks, as lots of attention paid to the storage temperatures, the need for ultra-low temperature storage for the Pfizer product, and each of them going through large, rigorous phase 3 clinical trials that with an intentionality of enrolling diverse populations, both in terms of race and ethnicity, including large cohorts with underlying diseases, and a variety of critical workers that were involved in the trials as well. Next slide, please. And I think just that both have, the data has been shared broadly, how effective these were against symptomatic COVID-19 disease and strong indications of prevention of severe disease. We still are waiting for more data over the next weeks, months, or years around the role of preventing asymptomatic infection, the role of the vaccines in preventing transmission and contributing to herd immunity, and the duration of immunity, as well as there weren't a lot of deaths in the trials to conclusively show protection against fatal disease. Next slide, please. The reactogenicity, the side effect profile of the vaccines, perhaps similar to the newer shingles vaccine, with reasonable amounts, moderate amounts of local and systemic side effects, but most of these are mild or moderate and last a few days of malaise or fatigue or chills or some of the side effects. Next slide, please. A lot of attention around the occurrence of anaphylaxis with this report last week in MMWR from CDC, and using one of the safety systems that Dr. Brooks mentioned, there's an identification of 21 cases of anaphylaxis in the first 10 days of administration at a rate of about 11 cases per million, about 10 times what you would see with the other routine immunizations. So this is being followed quite closely, as I'm sure you're all aware, and seen coverage or perhaps within your systems or may know of a case. Next slide, please. I think Dr. Brooks covered the various safety systems, just pointing out that the Vaccine Safety Data Link, or VSD system, is perhaps one of the higher quality, most detailed safety systems, and relies heavily on Kaiser Permanente data in Northern and Southern California. So for the immunizations being received in those systems. Next slide, please. So after the two we have, when will the next ones be available? The one that looks most promising next in line is the so-called Janssen or Johnson & Johnson vaccine, which is being evaluated in a one-dose trial. And the newspaper today from the New York Times saying that there may be data to provide to FDA by the end of January, similar to some other recent estimates, but notes that some of its production estimates may not be as high as initially projected. Next slide, please. As AAP members, what is the pace of vaccine development and evaluation in adolescents and children? Both Moderna and Pfizer have trials going down to age 12 years, with plans to go to younger years thereafter. In terms of, I believe there is one trial that is enrolling pregnant women, but over the last week since these vaccines have been available, a number of pregnant healthcare workers have been vaccinated in accordance with ACIP and CDC guidance that the choice is the risks and benefits, and the clinical decision can be based, pregnant women have the ability to consider receiving the vaccine, despite the lack of participation in clinical trials prior to the EUA. Briefly, each week, in terms of the numbers, which seem seem have been low compared to the need, having a few million doses in California in a population of 40 million. Each week at CDPH, we get an update of how many doses have been produced and are allotted to California. The federal government directs some of those to federal facilities such as the military or Indian Health Service. And then the rest of those doses are primarily provided to local health departments. And also the department also works with some large multi-county systems that span several counties to direct some doses to those entities. There is a nationwide program set up by CDC with 2 large pharmacy chains, which are immunizing skilled nursing facilities, assisted living facilities, and other long-term care centers. And then there's a few California facilities that we deliver vaccines, deliver allotments to, such as state hospitals and correctional medical facilities. Next slide, please. So I think I'm just going to proceed. This just talks about how the local health departments are making decisions. These are the doses, and showing that as of yesterday, that of the 2.4 to 2.5 million doses that have been shipped to clinical facilities, about a third of them we have records of giving. We're looking very closely. This topic of percentage doses given is had a lot of nationwide visibility, and concern about the pace of immunization and the effectiveness of the campaign in delivering the vaccine. So like other states, we're looking closely at this issue, including to the degree that are there both at the increasing infrastructure to deliver these vaccines, and looking and seeing in which ways we can improve, and working with local health departments, other providers in that analysis, looking at the allocation system and any ways that if there's any room for improvement throughout the system, but also wondering to what degree if there are vaccinators who haven't reported their doses yet, and whether that 800,000 doses is an underestimate. Where are we in terms of phasing? And I think, as Dr. Brooks said, we're in phase 1A with different counties and different facilities being at different further along or less far along in reaching all of their healthcare workers and long-term care residents. So while we're still, some are at the point where they can proceed to the early part of phase 1B. So as with the H1N1 pandemic and other situations, there's roughly in a similar place, but a lot of variation locally as supplies get out. Next slide, please. Looking ahead right now, I would imagine that many of you your concerns about vaccine at the moment, concerned about being one of these phase 1A healthcare workers. Eventually, your patient population may be eligible for vaccine on the pace of the clinical trials and the data on children. Some of you may be include 16 plus or adults in your practice. So these are some of the questions that are coming in with frequency. When and where can I get vaccinated? What tier am I in? When can we enroll? There's a website at the bottom which is a general resource for both the public and providers on the question about enrollment to receive vaccine. The rollout of enrollment has been at the direction of health departments until recently. We now have about 3,000 to 4,000, somewhere in the ballpark of 3,000 plus providers around the state enrolled in the system. Very few of them have received vaccine yet, given the relative scarcity of the supply. Many more will come in. I think in H1N1 there was up to 10,000 folks who enrolled. Given the demands on our enrollment system to get from 3,000 to 10,000, we'd ask you just to wait a little bit. There'll be some clear signals on when to come in and enroll before too long, but for the moment, especially if your patient population is going to be a while before they get vaccine, to ask you just to wait a bit on that enrollment in terms of weeks, days to weeks rather than a longer period than that. Next, so I'm sure some of these questions in terms of also, anyway, we'll get to that in the Q&A. That's fine. We can go on. So Dr. Brooks showed what the various steps were for Watts Healthcare to become enrolled and receive vaccine. And these are some of the criteria that providers have to attest to comply with when they sign the federal provider agreement. Complying with ACIP recommendations. An important one is reporting doses to registries, and such as CARE2, or if you're in San Diego, SDIR, in the Central Valley, part of the Central Valley Healthy Futures. I think for AAP members, this is not such a big deal, but for other adult immunizers, there's many of them who, where this joining the registry has been a part of their enrollment process that they've had to get through. I think many of these other practices will be very familiar to VFC providers and to pediatricians in general as we continue to go through the list. Because this is federal, some differences are because this is a federally purchased vaccine. There's no, not supposed to sell or seek reimbursement. You can bill for the vaccine, but not to sell it. You can bill insurers or seek for uninsured patients. You can seek reimbursement from HRSA, but to administer the vaccine regardless of the recipient's ability to pay. And because these are under EUA, there's not a vaccine information sheet. There's an EUA fact sheet that has to be provided, similar to the VIS for routine childhood vaccines. Next slide, please. And then these are the ones that are probably familiar to VFC providers in terms of complying with vaccine management practices, temperature monitoring, especially given the extreme temperature requirements of these vaccines, reporting supplies. There is a requirement to report to VAERS and to general asking for compliance with state and federal laws. Next slide, please. Some resource pages for you for now or in the over the near future. On the EasyIZ site, which is the California VFC general site, there is a California COVID vaccination program page with various information for providers. And that top link there, the guide to other vaccine-related websites, that first hyperlink. Next slide, please. Has a variety of links there. So along with going to the CDC or other websites, this is there's a listing of various resources around from administering vaccine to storage and handling to information about enrollment and the spectrum of resources. Next slide, please. So for your patient population, for your community who will have many of these same questions, these are some contact numbers to reach the state call center. When will I get vaccinated? What tier am I in? What resources are there? Where can I get more information about immunization? The public call centers for the public, and then for the providers, the EZIZ can direct providers to the provider call center. Next slide, please. So I see we're far along in the hour, but I hope we can still get through a number of questions, and thanks for your attention.
Thank you very much, Dr. Schechter. Yes, we have lots of questions for you. Let's see if I can at least get through a few. So the first one will put you on the spot. As of noon yesterday, California, the largest and most COVID-afflicted state, had administered only 26% of the doses it had received, which puts it in the bottom 10% of all states, compared to 35% nationally and 49% in Texas, the second largest state. So what can we learn from other states, and what can we do to speed up the administration of vaccines here?
Appreciate the question. I think try to address some of that with the screenshot of the current numbers. The total numbers of vaccines that the federal government has allocated also include a large reserve directed to those chain pharmacies so that they have enough doses to get to these very vulnerable assisted living and skilled nursing facilities. So those are a set of doses that some of those are waiting to be used. For the other chunk, the 2.4 million that was on the screenshot, and about the 30 to 40% numbers there, those numbers, that percentage has increased over recent days, and I think that coincides with the images in the media of stadiums in San Diego and Los Angeles and other places that are really ramping up their capacity, and that ramping up of capacity by both health departments and private systems has been occurring during the surge, and so it's hard to know to what degree the resource demands on care and responding to the other parts of the pandemic have also hampered our limited resources for vaccination. So I think we're trying to do an honest assessment of both of the state and local levels of how we can deliver more doses. And again, I think we're also curious to know whether that numerator of what's now up to 9, we're just under a million today. I think we'll hit the million. I think we'll hit the official million mark sometime overnight, but I'm guessing that number is actually higher because of either lag times or non-reporting or under-reporting, but despite the requirement to do so. So looking at all those factors and again, trying to see how we can all work to do better. But I'm very excited by up and down the state about the mobilization and the increased capacity. It doesn't, at the end of the day, the other frustration about the relatively small number of doses and compared to the number of people who need to be protected and want to be protected.
Great. I really appreciate that answer, and I know that everyone in public health, you and everybody in public health, has been working very hard Next question, how can physicians in practice help with vaccine distribution? Specifically, how can physicians become vaccine providers? And if they can't be a vaccine provider, how can they identify high-risk patients and get them immunized?
So I think over the next weeks and months, going back to the enrollment process, there will be the ability for routine vaccinators to join the few thousand that are already enrolled and the hundreds who have received vaccines so far. So there will be the opportunity to enroll to become eligible to receive vaccine, and then over as Dr. Brooks's chart showed, the pace of the flow of vaccine is another rate determining step in terms of how many providers who have enrolled can get those scarce doses. So over time, I'm not sure what that time is, but going in the spring or summer, I think this is going to look a lot like seasonal flu vaccine, where there's the normal immunizing infrastructure for whatever those appropriate age groups are, in the regular places of care, along with a strong, perhaps an increased pharmacy presence, but at least as strong a pharmacy presence as flu, and probably stronger than that, along with the Dodger Stadium options, and that there will be a menu. But to get from here to there is going to take time and doses to build that capacity, and a very rough time to have scarce doses given the surge and the immediate impact, the direct impact of the disease all around us.
Can you talk a little bit more about the timeline for children? When will we have more data from the trials, and when do you think the vaccine might be approved for children?
I don't have a lot of details other than the Pfizer data down to 12. The Pfizer study down to 12 has been going on for a few months now, and Moderna some weeks. So hope for trial data by summer or later, and then and I'm not sure if they are starting their younger ages before the end of the 12 to 16 evaluation, or whether they'll be in parallel or serial in terms of. So I would think there's a prospect of having doses for preteens in the second half of the year, but subject to enrollment, disease rates, and regulatory review.
Thanks. How long will infection control measures, physical distancing and mask wearing continue once vaccine has been administered?
I think that's also no time soon for relaxation. So certainly appreciate everyone's practice and modeling and messaging around the basics for distancing, masking, hand washing, and such, so that some of the factors to be watching for relaxation would be the level of continued transmission, what we learn about what's learned about how if vaccine is presented is reducing colonization and shedding and transmission. So are people walking around who are immunized asymptomatically transmitting or not? And just as with increasing rates of immunization and decreased levels of disease in the community. So I think it will be some time before relaxation of those foundational measures.
All right, one last question. We actually received many requests and questions about volunteering to help administer vaccines. These came from nurses, physicians, pediatric offices, optometrists, even school nurses. So how can they volunteer?
So I was listening to Dr. Ball shortly before we started talk about the Orange County efforts to reach out and volunteer. So checking at a few different places with your local health department, and whether there's a existing medical reserve corps or staffing requests for delivery for immunizers, and we'll have more and more an ability on the state level to direct volunteers as well. But a lot of this will be, a lot of the delivery is coordinated and on the local level. I believe that both California Medical Association and perhaps California AAP are exploring ways to facilitate fellow state members and fellows in getting linked up to local efforts. And I appreciate that California AAP members and friends are amongst the most experienced vaccinators in the state, and that's a resource that certainly need to make the most of. So appreciate the questions, and I would start first at the local health department level, and we should hopefully at the state level we'll make that a little easier over the next weeks.
Yeah, so my personal experience is so California Medical Association, a lot of the county medical associations are starting to organize volunteer groups. I bet professional organizations for nurses and others are probably doing the same. But while we're waiting for that, I agree with someone who posted a question. This needs to be an all hands on deck endeavor. People like me have had both of my vaccines already. I feel very comfortable vaccinating people. It's what we do as a living as a pediatrician. And so our county health department put out a call for volunteers, and I signed up online, and someone called me today to assign me some shifts. So I'll be working at Disneyland sometime soon. So if you need me, I will be on Dumbo.
Happiest shots on earth.
Wonderful. Well, thank you very much. That brings us to the end. We just have a couple of extra slides.
Those are extras. They don't need to be shown.
Okay. And after the call, there will be an evaluation. Please do fill out the evaluation, as this helps us to prepare for future conversations. Thank you very much, everybody, for joining us this evening. Thank you very much to our speakers. Right. Take care, everybody.
Thank you.
Thank you.
Thank you.